Yeah. Good evening, everybody. Thank you all for attending our lecture series in general surgery. Special thanks to all our speakers and chairpersons, especially Dr. Ajay Khanna, Dr. Thampi, and Dr. Dharmesh and Dr. Goel, as well as Dr. Deshpande, uh, for agreeing for short notice for our program. I would ask Dr. Niranjan Agarwal to start the session, and then I'll introduce the chairperson, and then chairperson would introduce the speakers, and then we'll start the session. So over to Dr. Niranjan Agarwal.
Thank you, Rajesh. Welcome once again, dear friends. It is indeed my proud privilege to welcome you once again. Now, this is the 10th series in general surgery, and the topics today are going to cover the neck swellings. And I am happy to inform that we have got very talented speakers today from across the country. Dr. Ajay Khanna is a teacher of teacher, and he's from Varanasi. The chairpersons are going to introduce them in detail. Dr. Vaidya from Nagpur and Dr. Thampi, who's not a surgeon, a respiratory specialist coming among our crowd today. So we do have a very wide spectrum of speakers for the Mumbai Surgical Society. So I am sure my both chairperson from Mumbai Surgical Society are going to get the best out of them today. And delegates, if you have any questions, don't hesitate to put your hands up. Time permitted, you will be allowed to talk. And if not, at least put it in the chat box. Don't go back with your doubts unsolved. These are for you. Ask your questions, get your doubts solved. And at the end, again, thank you, Juventus, for supporting in our endeavor. Over to you, Rajesh, to introduce the chairpersons.
Yeah. Thank you, Niranjan. And without wasting time, we'll start the session. Our two eminent chairpersons for today are Dr. Dharmesh Panchal and Dr. Gautam Goel. Dr. Dharmesh Panchal is a consultant. Good evening. Good evening. Is a consultant surgeon. Is a practicing surgeon at the Holy Spirit Hospital. Is an accredited DNB teachers for general surgery at Holy Spirit Hospital. Dr. Dharmesh has a number of presentations to his credit, both nationally as well as internationally. Dr. Dharmesh's keen interest is in advanced laparoscopic surgery. So, Dharmesh Panchal is a dear friend of mine also, and Dr. Gautam Goel. Dr. Gautam Goel is a practicing general and laparoscopic surgeon. His main field of interest is general surgery and advanced laparoscopic surgery. Dr. Gautam is attached to Shushusha Hospital and has many presentations to his credit, both nationally as well as internationally. So over to Dr. Dharmesh and Dr. Gautam Goel to take over the proceedings. Thank you.
Dharmesh, you'd like to say a few words before we get going?
Dr. Gautam Goel, I think we can introduce Dr. Ajay Khanna, so that we can start with the...
Yeah, we just like to set some rules over here in the sense, some things that will help us run through this very well. If the speakers can keep the talk to about 25 minutes, that will keep the next set of speakers enough time to share their presentations, and we may be able to also take some question and answers from the delegates. The other thing is, I think from both Dharmesh and my side, I would like to thank the MSS and especially Rajesh, the Honorary Secretary, and the President Niranjan Agarwal for having us chair this session and be the part of this wonderful series of lectures that have been going on. And we're privileged to be there. More than that, as I realize, my huge privilege comes in introducing Dr. Professor Ajay Khanna. I mean, his achievements are so much beyond probably even the hair that I hold in my head. And he's been a professor and ex-head of Department of Surgery, from the Institute of Medical Sciences, Banaras, and the University at Varanasi. He's been a governing council member of the ASI from 2011 to 16. He's been the vice president of ACR SI North Zone, president of the UP chapter of ASI. He's published 350 papers, 5 books, 79 chapters, has multiple students under him, guided 52 with their thesis. Without taking too much of his time, I think it's best that we listen to him and listen to him very keenly. Dr. Khanna, please can I request you to take this forward with your talk on neck swellings. Before we start, may I also request all delegates to mute themselves at any point so that we don't land up with the background sound.
Thank you very much, Dr. Gautam, for a nice introduction. I'm really thankful to Niranjan and Rajesh for inviting me to share my views on the evaluation of the neck swelling. I know Niranjan for a very long time, as a part of the ACRSI, and he has been so active. And the type of the activity he's carrying out under the Mumbai Surgical Society is just amazing, which is there, It's just imaginary thing that he's continuing almost for about the whole year. He's having 3 lectures. So that's tremendous achievement which he has placed. So I must compliment Niranjan for all these activities. So I will start with my presentation on evaluation of the neck swelling. Can you see my slides now? Dr. Gautam, can you see my slides?
Yeah, we can, sir.
Yes, sir. Yes, sir.
Yeah,
Yes,
we
sir.
can see you, we can hear you.
Right. Thank you very much. So when we talk of the neck swelling, I think probably neck is the most complex organ of the body, if I say after the brain. There are so many structures which are there in the neck, and so many swellings can come out of that. Almost about, it is mentioned, about 85 types of swellings can arise in the neck. It extends from one bone to the other bone, from the mandible to the clavicle. We have been always talking about the anterior and the posterior triangle, but there's a big part which is there on the posterior side. What is the nape of the neck? There, and there are many swellings which can come in that area also. And then, there is always in the anterior triangle, posterior triangle, we say the anterior triangle is bounded by the anterior border of the sternocleidomastoid. The posterior triangle is bounded by the posterior border of the sternocleidomastoid. But what happens? There is a big area underneath the sternocleidomastoid. And there are so many swellings which will come underneath the sternocleidomastoid. And usually they are joined along with the anterior triangle. You have to define what is the neck swelling. It is not only it is visible swelling or a palpable swelling, but even if it's seen on the imaging studies, you will call that is having a neck swelling. And several development groups have shown that you can have these swellings right from the mandible to the clavicle, and they can be the various varieties. And one of the very important things which is there, if in an adult patient who has got a mass in the neck of the recent origin, which is more than 2 weeks, then it should be always considered that it is a malignant mass, and you have to investigate this patient very thoroughly to find out that whether that particular mass is a primary or is it a secondary which has come in the neck. So look at the complex anatomy of the neck which is there. It has got so many muscles, so many blood vessels, so many nerves, so many lymph nodes. Look at the number of the lymph nodes which are there. It is 200 to 800 nodes are there in the neck. And then all those vital structures, whether it is the trachea or the larynx, esophagus, thyroid, parathyroid, all these are situated in the neck, and a swelling can come from any of these structures. So basically, you can divide your swelling of the neck into the various ways. Is it as per location? That is probably the most important. Then as per etiology. As per duration, there is a rule of 7 which is there. If a swelling is there for 7 days, it is probably inflammatory swelling. If it is 7 months, it's a neoplastic. If the 7 years is there, it's a congenital swelling. And then it can be from the various tissue of origin, as per the age of the patient, and as per number of the swellings. And in the number of the swellings, take it for granted, if there are multiple swellings in the neck are there, these swellings are from the lymph nodes, until unless they are proved otherwise. So it can be inflammatory swelling, or a congenital swelling, or a traumatic swelling, or a neoplastic swelling. And so many types of the swelling, the inflammatory, maybe the various other lymph nodes, maybe because of tuberculosis, salivary, various type of inflammation, the congenital cysts which are there, or a congenital variety, the thyroglossal lymphangioma, dermoid cyst, laryngocele, pharyngeal diverticulum, thymic cyst, branchial cyst, ranula, all those are the congenital one. And in the neoplastic, which can be a primary or it can be a secondary. Primary are mainly the lymph nodes is the lymphoma, and the secondaries, they come somewhere from the head and neck area, or even they can come from the abdomen or from the chest also. If they are in the lower cervical region, it may be there from the testicular tumor. So there are different types of the neoplastic swellings which can be there in the neck. And inflammatory, very specific type of the inflammation, there can be Ludwig angina or peritonsillar abscess may be there, or a parapharyngeal abscess may be there, or a retropharyngeal abscess may be there, which may present as a swelling in the neck. And then traumatic. At birth, if a child gets trauma to the sternocleidomastoid during the delivery, he can develop later on the sternocleidomastoid tumor. If there's a trauma to the neck is there, especially if it's a blunt trauma, it can lead to the serums of the various major vessels, or at surgery, you have cut the nerves and you are not very careful in cutting, it can form the neuromas in the neck, and that can present as a neck swelling. So look at the midline swelling which are there, starting from the top, from the floor of the mouth. They can be the submental lymph nodes, a dermoid may be there, Ludwig may be there, the ranula may be there, subhyoid bursitis may be there, there can be thyroglossal cyst may be there, or the Delphian nodes may be there, or a thyroid isthmus tumor in the midline, or advanced larynx malignancy is there that can present as a swelling in the midline, or in the suprasternal space of burn which is there, you can have the various swellings. And these swellings in the suprasternal space of burn may be a lipoma, or a sequestration dermoid, or a gamma, or a thymus swelling may come in the neck, or various great vessels, aneurysms, the innominate, the subclavian, aorta may be presenting the neck, and the cold abscess definitely come. Tuberculosis can come anywhere in the neck. And in the lateral swellings, whether it is the carotid triangle, or whether it is the submandibular triangle, or in the posterior triangle, there are the different types of the swellings which are there. So if the submandibular triangle is there, which is bounded by the lower border of the mandible, the lower border of the mandible is there, or it can be from the bounded with the anterior and the posterior belly of the digastric. You can have all these swellings, the lymph nodes, the salivary gland, the plunging ranula, Ludwig's, the lateral sublingual dermoid, and tumors of the mandible. Similarly, in the carotid triangle, which is bounded by the sternocleidomastoid here and the digastric, and here is the superior belly of the omohyoid, which is there. It forms the carotid triangle, and there can be a branchial cyst, or lymph node mass, or aneurysm may be there, or a thyroid swelling will be presenting in that area, or a laryngocele, or the pharyngeal pouch, a lymphangioma, the sternocleidomastoid tumor, or the neurofibroma of the vessel may be there. And then in the posterior triangle here, on the posterior side here, and that's what I was saying, that this is the anterior border which is forming the carotid triangle here, and this is the posterior border which is forming the posterior triangle. So what happens underneath here, there's a big part of the neck which is there, and usually it is combined with the anterior triangles. Like a branchial cyst will be there, it will be underneath in this area as well in the anterior, in the carotid triangle here. So it is combined along with the anterior. So in the posterior triangle, you can have a solid swelling, like the metastasis, or there can be tuberculosis, lymphoma, lipoma. Cervical rib, especially the bony variety, they can be present in this area here as a solid mass here. Or the Pancoast tumor may be there, a tumor from the apex of the lung may be presenting with a swelling in the neck. It can be cystic swelling, the lymphangioma, the hemangioma, the cold abscess, or it can be pulsatile swelling from the various arteries which are there in the neck. And then in the nape of the neck, now this is the nape of the neck. So this is also a big part of the neck is there. So there can be various types of swellings that can come in this area. You may, many times you find the diffuse lipoma is there, or a carbuncle in a diabetic patient, it may be there, or the skin infection, or any of the occipital lymph nodes which are there in any type of the malignancy, or sometimes in the congenital, it can be encompassed. to be presenting in this area. So if you look at the probability of the neck mass according to the etiology and the age group which is there. So in a pediatric patient of less than 15 years, majority are the inflammatory, few are congenital, and very less are the neoplastic. While the young adult, almost they are equally divided. And in the elderly patient, much more are the neoplastic. Sometimes they may be congenital and sometimes they get inflammatory. So age of the patient is very important to make that what is the diagnosis of that neck swelling. So in any case of the neck swelling, like in the breast, we say we have to carry out the triple assessment. In the neck, we do the quadruple assessment. And quadruple assessment is that you take a good history and carry out the examination. You do the imaging studies, which can be the various types. You do the pathological studying to make the final diagnosis. And then in many cases, you require to carry out the endoscopy. And sometimes you have to assist it with the other ancillary methods that are there in evaluation of the neck. So what are the steps of evaluation of a neck swelling? Take a very good history, do a very good examination. ENT examination may be part of your examination of the neck. Ultrasound is the first investigation to be carried out in majority of the cases. And then FNAC and FNAP should be done. And you must make sure that you are not dealing with a vascular case. Otherwise, there will be a problem if you do the FNAC or FNAB. And then you do the X-ray. The chest may be done in some cases. The CT is the workhorse, and MRI may be done, especially for certain soft tissues. The pan endoscopy has to be carried out. Excisional biopsy may be carried out, and the frozen section, and sometimes the neck section may give you the final diagnosis. And few ancillary tests has to be carried out to evaluate the case of the neck swelling. So how to examine the neck? This is important from the students, that you have to examine the patient in the sitting posture, and you must expose both the clavicles when you're carrying out this examination. Inspection is done from the front, and at that time you ask the patient to do the swallowing in a center swelling or protruding the tongue in a center swelling. You examine also the neck from the back side also by flexing the chin of the patient and moving the neck slightly on that side, and that would relax the various muscles, and you can do a good examination. And it is always advisable that you ask the patient to pinpoint that which is the site of that swelling, and then you examine that area very carefully. You have to examine the neck bilaterally. You have to palpate all the palpable nodes, starting from level 1 to level 6 nodes which are there. Level 7 is usually not palpable in the neck. And in a case of suspected malignancy, you have to definitely carry out the various type of the examination, like the nasopharynx, the tonsil examination, the base of the tongue, the piriform fossa has to be examined. And in those cases, definitely the role of scopy comes. You have to carry out the various scopy for examination of these inaccessible areas. Just again to remember that what are the parts for the physical examination for any lump. Only it will be abdominal lump or any peripheral lump or a neck lump. Remember, 5 students, 3 teachers go for campfire. By these, you can probably not miss the parts of the, so the site, size, shape, surface, scar and the skin, tenderness, transformation, temperature, consistency, attachment, mobility, pulsation, fluctuation. So all these things are carried out for any lump and also for the neck lump. So plain X-ray usually is not required, but sometimes it can give you very important clues, like the cervical rib is there. You can very well see on a plain X-ray if it is a calcified type of the cervical rib which is there. You can see the various calcifications may be there. And this is very important, especially when you're going to do the thyroid surgery. And you want to see that what is happening to the trachea. Is it a compressed trachea or it's a deviated trachea? And that can be very well seen on the anterior posterior view of the neck or the lateral view of the neck. to tell both for the surgeons and for the anesthetist that where is the track. Now, ultrasound of the neck should be the first investigation for a neck swelling, especially for the pediatric neck masses. Is very important. Differentiate the cystic from the solid, and definitely the vascular masses. It will tell you that this is a vascular mass by the duplex scan which is there, and you have to be careful that you are not putting your needle inside a vascular mass. The CT scan is a workhorse imaging modality for adult neck mass. So if you find there are lymph nodes which are there in the neck or any swelling which is there, you have to decide about that from where it is arising, how many of them are there, and what is the relation to the vital structures. The thyroid may be fixed to the carotids or the internal jugular vein, and that will make the surgery very difficult. So you have to carry out the CT scan of the neck for that. So it provides you the three-dimensional relationship, and it's very good for the bones. So if you have to really want to do, like see the mandible, whether that is getting involved or not, or the clavicle is getting involved, you do the CT of the neck, and CT is very good for the bones. And the MRI is good for the soft tissues, and especially for the salivary glands and for the tongue, it is very important investigation. In fact, the investigation of choice for a carcinoma of the tongue is the MRI. You can look for the various nerve involvement. So if you want to see the nerve involvement, you would carry out the MRI for these patients. And definitely if you are planning for any radioactive iodine treatment for that, you do not want to give the contrast to the patient for the CCT. So the MRI is the choice in those cases. And the radionuclide scan, definitely, it is now reserved mainly for the post-operative. So you have to carried out a total thyroidectomy, and then you want to see that what is the thyroid tissue left or not. So you carry out the radionuclide scan. So for the thyroid and the parathyroid, this scan is important, though it was used much more in the preoperative setting, but now the main use of the radionuclide scan remains only in the post-operative period, and very few cases in the preoperative period to make a diagnosis. And then the positron emission tomography is another investigation, especially for the malignancies of the head and neck. It can be used for searching the primary. Many times there are lymph nodes are there, but you are not able to search where is the primary. In those cases, the positron emission tomography is very good, and especially also for the follow-up of the patient. You are not sure that there is a small nodule which is there, which is a scar or it's a recurrence is there. And for that, the positron emission tomography gives you the answer for that. And then the CT MRI angiography for any type of vascular reason, or any aneurysmal disease which is there, or a carotid body tumor is there, for the carrying out the great vessel surgery, and then for carrying out the embolization. Embolization is a very important treatment in the head and neck swellings which are there. So for that, you carry out the angiography. And then the fine needle aspiration cytology, in fact, is a very good thing which is there in the neck swelling, and it can give you the diagnosis within few minutes and hours. Is it safe? It is rapid. It is inexpensive. Avoid the open biopsy with a minimal complication, but you have to be again careful, as I told again and again. For a vascular tumor, you should not put the needle in there. And then the triple endoscopy, or as a quadruple assessment, or the especially like for the nodes which are there in the neck, and you are not able to find out that from where those nodes are coming out. So you do the laryngoscopy, you do the esophagoscopy, the bronchoscopy, or the pan endoscopy, which also includes the nasopharyngoscopy, to find out that where is the primary. And then few ancillary tests, like for the thyroid, you will carry out the hormones. For the parathyroid, you will carry out the serum calcium, the parathormones. So those ancillary tests can be done along with other quadruple assessment there. And then sometimes you require the examination and anesthesia for the areas which are not accessible, like the base of the tongue, the tonsillar fossa, and the posterior pharyngeal wall. You're not able to assess. So you may require the examination and anesthesia. And when you're carrying out it, you can do the various types of scopies for these patients to find out the primary, and you can do the biopsy, good biopsy, to confirm the diagnosis. So that is in general about evaluation of the neck swelling. Now I will very briefly discuss about the swellings which are there in the neck very briefly, and what are the salient things you have to know for that. A branchial cyst, age is 15 to 25, present in the upper triangle, soft cystic fluctuant swelling, and FNAC is in fact diagnosis that it shows the cholesterol crystal. So if you find that the cholesterol crystals in a FNAC, you may almost make a diagnosis of the branchial cyst. A thyroglossal cyst, basically it's a type of dermoid. It can be present anywhere in the neck, starting the floor of the mouth to the suprasternal area, and it may be on the left lateral side. So thyroglossal duct, which is there, it slightly deviates on the left side. So it may be slightly on the left side rather than exactly in the midline. Usual age is 15 to 30 years. It moves with protrusion of the tongue. That is the diagnostic thing. And when you plan for excision of that, you must do the thyroid scan for these patients, because that may be only functioning thyroid. So you have to be careful about that. And then the ranula is basically on the floor of the mouth, and it is brilliantly transparent swelling. Carotid body tumor, typically in the upper triangle. And the typical thing which is there, this swelling will move only transversely and not vertically. And that is the diagnostic feature of a carotid body tumor, or a tumor arising of vagus, which is there, that will also have the similar type of the presentation. And then there can be cystic hygroma. It is a transparent swelling. There are mainly two transparent swellings which are there in the neck, the ranula and the lymphangioma. Sometimes the branchial cyst may also be the transparent. And it can be hemangioma or the vascular malformation. If the venous variety is there, it may be compressible swelling. The parotid swelling may be different types. It's a parotitis, or the parotid tumors may be there. And sometimes they can be so large tumor may be there. Now, this man had this tumor for 25 years. It weighed 8.5 kilogram, and that weight he was carrying on his neck and the head, and he was sleeping on that tumor because of such big tumor. And definitely you have to carry out the facial examination, because the facial nerve is the most important thing. When you're carrying the surgery for the parotid, you have to identify all the branches of facial nerve. Then the thyroid swelling can be different goiters may be there. It can be a inflammatory, it may be hypothyroid or hyperthyroid, or the various neoplastic swellings may be there. And the parathyroid adenomas may present the Crohn's, Mons, bone stones, and fatigue over tones, and you have to excise that. Pharyngeal diverticulum is there, which characteristically diagnosed by the halitosis and the regurgitation of food which is there, and you hear the sound of the regurgitation. Sternomastoid tumor, as I told you, in the middle third of the sternocleidomastoid, and may have the torticollis. The cervical rib is there, which can present a bony type in the posterior triangle, and you can find the thrill and view on that. Laryngocele will present with a swelling in the upper part of the neck, and it moves to deglutition. So that is another swelling which moves to the deglutition. The Ludwigina inflammation in the submandibular space, and you require the surgery for that. A sublingual dermoid may be there. It's again a sequential type of the dermoid. You have to differentiate between the ranula and the thyroglossal cyst. This will be not transparent, while the ranula will be transparent. A subhyoid bursitis to be differentiated from the thyroglossal cyst. Subhyoid bursitis is placed more transversely as compared to the thyroglossal cyst, which is more placed vertically. Submandibular salivary gland has to be discussed. There can be aneurysm in the common carotid artery, the positized swelling. Schwannoma of the neck may be there. As I told you again, this is a carotid body tumor. But when you touch this schwannoma which is there, the patient may have the cuff along with the bradycardia may be there. Pancoast tumor is there, or the apex of the lung which is there, is a hard fixed mass and may present with the Horner syndrome. Lymph nodes you have to definitely examine all from level 1 to 6 and also 7-1 if possible, which can be because the reactive or tubercular or secondaries of the lymphoma, or there are various types of the infective pathology. And COVID is one which also gives the palpable lymph nodes. COVID-related neck problems, maybe the neck pain, the neck stiffness, parotitis has been known with the COVID, lymphadenitis, and the rashes may be there on the neck. To specific sign, I will not again, just the thyroglossal cyst moves with the protrusion of the tongue, the thyroid moves with deglutition, the ranula is transparent, carotid body tumor, there is restricted mobility, up, down, neurofibroma, initiator, puff, the lymph nodes are used in multiple, and carotid will give rise to the elevation of the ear. Now, there's a concept of one-stop neck clinic, which has been started in the King's College Hospital in UK in 2012, where there's a combination of persons who are there. There is a maxillofacial surgeon, the oral surgeons are there, hematologist is there, a cytopathologist is there, and the radiologists are there. And just like we have got the rapid breast clinics or one-stop breast clinic, similarly, we can have the one-stop neck lump clinic to make a very early diagnosis. And this is just, I'm giving you the reference for that, that many of these cysts, which are there, cystic swelling, will not require the excisional surgery. Sclerotherapy, though it is there for a very long time, but it has now been used for almost all types of cystic swellings on the neck, a ranula, a thyroglossal cyst, a branchial cyst, all can be treated by the sclerotherapy. So, friends, the diagnosis of neck swelling depends on the age, location, and duration of the lump. And in adults, any swelling more than 2 weeks duration should be taken as malignant until unless proved otherwise. Thank you very much.
Thank you very much, Professor Khanna. That was, it's amazing how much you actually covered in this entire thing. And with your pictorials, we could make out that you probably experienced all the types of swellings in your practice. So could you go ahead with your quiz, please? That's something that you had set up.
Dr. Gautam.
Anji.
Hello.
Anji, Professor Khanna, you can go ahead with your quiz. We have some time.
Hello.
I can hear you.
Are you able to listen me?
We can hear you.
You are audible, sir. You can talk. Continue to talk.
Hello.
We can hear you. Professor Khanna, we can hear you.
Hello.
Sir, you are audible. Dr. Khanna, we can hear you.
No voice is there.
You may have been muted by somebody.
No, we can hear him. No, he's not muted.
He's not able to hear us actually at this point.
He may have muted his.
No, now I can hear you.
Yeah, we can hear you clearly.
So should I stop here or because I
ask a question?
Niranjan?
Yeah, can I ask a question, sir?
Yeah, please.
Sir, you said that we should do a FNAC in this neck swellings, but many a time our respiratory physician, one of them is waiting quietly there to be heard by us. They insist we directly do a lymph node biopsy. We don't do a FNAC nowadays. What is your take? And secondly, sometimes there are tumors like carotid body tumors, etc. If you clinically suspect, where all you should avoid an FNAC? Let me put it in a simple way. Where all we must avoid an FNAC?
I think from the diagnostic point of view, because if you carry out the excisional biopsy, it is going to be a traumatic one. FNAC is a relative non-traumatic, right? So that is why it proceeds over the, definitely you are going to, like a case of lymphoma is, let us say. Now in the lymphoma, if you do the FNAC, you may just say the patient has a lymphoma, but what type of the lymphoma it is, you require a biopsy for that. So definitely if you want, but like a branchial cyst is there, or like a thyroglossal cyst is there, those swellings will not require the biopsy, but they will require the exact treatment for that. That will excision of that. So FNAC is a primary one which is there to make a diagnosis, but you have to be careful. I have again and again told that if you are suspecting any vascular part which is there, like a patient has a carotid body tumor is there, or there is an aneurysm one is there, or even if there is a vascular malformation is there, any vascular thing which is there, you have to avoid the FNAC, and that is why the ultrasound becomes the prime investigation before you carry out the FNAC for these patients to make sure that they are not vascular.
I think if you're sure that the diagnosis is going in favor of lymphadenopathy, then probably you may be justified in just going for a biopsy right away. That way you can get tissue for your gene expert, tissue for culture.
That's
That's
what
the
I'm
only
saying.
way. Yeah,
That's what I'm saying.
that's what I think what the respiratory physicians are trying to tell us, when you can obviate the FNACs.
No, you do not require to obviate the FNAC. FNAC is a simple test.
Yes.
Just putting a small needle of 22 gauge there, just like taking the blood from any patient. It's like a venipuncture which you're carrying out for taking the blood from any patient. So 22 gauge needle you are putting there, or 23 gauge needle you are putting, and you get a not, I will not say the final diagnosis, but definitely you are clued toward that what is. Now let me take over the lymph nodes which is there. If there is a node which is there in the neck, and you think it is the malignancy which is there, the primary somewhere. So if you just put a needle there, if you find the squamous cell carcinoma in that, you will always trace for the oropharynx and all this. But if it is adenocarcinoma, it comes out from there, then you will trace for the lower part, the breast or the abdomen you trace. So that definitely gives you the clue before you make a biopsy of that. It gives you the clue that in what way your investigation should go there.
We get references, quite a few, from the respiratory physicians asking for a biopsy right away. I mean, they are not in favor of asking for an FNAC, but I think probably they're very sure if this is probably a case of Cox, and we just need further evaluation on the type of tuberculosis, or to look for any resistance, look for other causes.
Sure.
Dharmesh, there is a question in the chat box.
There's a question, from Shyam Borkar saying, do I need a tissue diagnosis if I'm sure about the diagnosis on clinical examination in case of benign etiology?
In case of?
Benign etiology.
Benign etiology. No, I do not think that is required for that. If you are sure over the FNAC and clinical also. No, it has the clinical, like a case of bronchial cyst is there. Clinically, you have made a diagnosis. You do the FNAC, you find the cholesterol is there. You go ahead and do a treatment for that. And treatment may be in form of sclerotherapy or excision of the bronchial cyst.
If you're sure if it's a lipoma, you don't need to do an FNAC. Clinically, if you are confident, you can just go ahead with the surgery right away.
No, but still, there will be differential diagnosis of that.
There's always, as the question says, that if they're sure on the clinical examination, then you can go ahead with the excision biopsy right away.
I guess as a take-home,
that's what the question was.
Right.
Okay, if I'm sure of the diagnosis, do I need to do an FNAC for tissue diagnosis? That's what the query was.
No, I think probably you cannot make a firm diagnosis clinically only. The swelling which is underneath the skin is there. So it may be just an infection may be there, which may be causing swelling there. It may be neoplasm, benign neoplasm may be there. It may be lipoma may be there. Neurofibroma may be there. So I think you require to have your diagnosis. Clinically, it is okay that probably you will make a diagnosis, but you have to confirm the diagnosis by carrying out some investigation.
So I think we would take home a message over here that before we poke in a needle, ultrasound examination is worthwhile. So we do not get into vascular structures, which we may underdiagnose at some point. And if we are sure about the diagnosis with imaging, then we may go ahead with probably a biopsy or something if it's a requirement, or maybe just do an FNA prior to that based on the clinical setting for that point.
Definitely.
Is that going to be fair?
There are
carry out the ultrasound.
Yeah, there are some
carry out the ultrasound.
Great.
Carry out the ultrasound after the clinical examination.
Right.
Put a fine needle and make a diagnosis. Still, if you are not able to make, or you want to more precise that particular one, as I told in the case of lymphoma, you want to see that what type of the cells which are there, and in those cases go for the excision biopsy, or even the people they have gone even for the radical section to make a final diagnosis for that all purpose. So those are extreme things which are there, but these are the initial things that should be carried out.
Gautam, take the next lecture. Is 11.
Yeah, I think we'll do that. Professor Khanna, can we do your little quiz on the end and take on the next speaker for the moment?
Sure.
Yeah. So, Dharmesh, could you please request Dr. Abhishek Vaidya to take on, please? Thanks.
I think I'll just say a few words about Dr. Abhishek Vaidya. Dr. Abhishek Vaidya is an MS in ENT from a prestigious KM Hospital, Mumbai, and followed by a Homi Baba National Fellowship in Head Neck Surgery at Tata Memorial Hospital. Currently, he's a consultant head and neck oncosurgeon practicing at the National Cancer Institute in Nagpur and assistant professor in ENT at the NKP Salve Institute of Medical Sciences at Nagpur. His areas of interest include thyroid surgery, skull-based surgery, endoscopic sinus and skull-based surgery, and laryngeal surgery. He has an IFHNOS fellowship from the Memorial Sloan Kettering Cancer Center at New York, and he has authored 5 books, chapters, including 2 on thyroid, and more than a dozen international publications. He has several international meeting presentations, including the best paper category at the IFHNOS and AHNS 2015 and the World Cancer on Thyroid Cancer in 2013. He's a member of the FHNO and an executive committee member and an executive member of the ISTS also. He's an organizing team member of the Chikladhara Thyroid Workshop. I think for so many accomplishments at a young age shows his dedication and commitment to further his work in ENT oncosurgery. I think Abhishek, whether you can just start your presentation. He will be speaking on management of salivary gland tumors.
Thank you so much. At the very outset, I must thank the Mumbai Surgical Society for giving me an opportunity to present in your very esteemed forum. I am in the midst of absolutely amazing company. Professor Khanna, your talk was absolutely brilliant. And I'm going to talk upon a very little portion of what you just spoke about. I'm going to talk about salivary gland tumors. So without further ado, here we go. So we've already discussed about this, that the major salivary glands in the body can be divided into the major and the minor. The major are of 3 main types: carotid, submandibular, and sublingual. The minor salivary glands are those which are distributed all over the upper aerodigestive tract. If you look at the incidence, there are not many large series, which tell you about the actual world incidence of these malignancies. The largest series is from MSKCC, and it was done by Spiro, who was, the predecessor to Dr. Shah, who's also actually now retired, and that was just about 2,800 cases over 35 years. There are no Globocon estimates. We know that they contribute about 3 to 5% of head and neck tumors, but most of our data comes from the SEER analysis, and we know that the incidence rate is about 12 per 100 lakh per a million person a year, and there is a slight more preponderance in males. So let's look at how these tumors can be classified. And they can be classified according to histology, they can be classified according to location, and also, more importantly, in my opinion, according to grade or risk stratification. Let's look at these. So this is the 2017 WHO classification of salivary gland tumors. And you see all the red boxes, these are the additions. So it's already a huge and very exhaustive list, and there are new additions being made during subsequent editions. So it's a huge list to be aware of. According to the sites, as I said, major and minor. The major are mainly in the carotid, submandibular, and sublingual, and I'll give a simple thumb rule to understand their distribution. In the carotid, 80% are benign, and only about 20% will be malignant. 80% of these benign will be pleomorphic adenomas. So about 65% of carotid tumors are pleomorphic adenomas. In the submandibular gland, half will be benign and half will be malignant. In the sublingual, 80% will be malignant. So that's inverse of what we see in carotid. In the minor salivary gland tumors, indeed, they are seen all over the upper aerodigestive tract. And when I was in TMH, we kind of had 2 papers regarding the minor salivary gland tumors of the oral cavity, which you see on the left, and of the paranasal sinuses, which you see on the right. And if you can see that in the oral cavity, close to 90% were malignant, and in the paranasal tract, all of them are malignant. So that's the high preponderance of malignancy in minor salivary gland tumors. Finally, risk stratification. This, according to me, is one of the most important classification of salivary gland tumors. So if you look at the WHO classification, they can be again classified into low risk and high risk. And I'm not going to go into the details of these, but I'm going to highlight a few important ones. Actinic cell carcinoma, low-grade mucoepidermoid carcinoma, polymorphous low-grade adenocarcinoma, clear cell carcinoma. These are some very understandable low-risk cancers. On the other hand, the high risk would be high-grade mucoepidermoid carcinoma, adenoid cystic carcinoma. Carcinoma X pleomorphic adenoma is one of the most aggressive tumors of head and neck, and carcinosarcoma. And according to grade, they can be classified into low, intermediate, and high. Needless to say that most of the high risk are intermediate or high risk grades. And indeed, grade may be more important than stage in salivary gland tumors, and this has been amply evidenced in the large series which I have aforementioned by Spiro. Grade indeed is more important than stage in salivary gland tumors. So let's look at the presentation. This is a slightly busy slide, but we'll go one by one. So bear with me. For benign tumors of the parotid, usually it's a slow growing and painless mass, usually arising from the tail of the superficial lobe. And as Professor Khanna rightly pointed out, it produces a bulge below the ear lobule and causes a lifting up of the ear lobule. This is a characteristic of a parotid mass, usually benign. On the other hand, when malignant, they have rapid growth. Pain may be present as a presenting feature. Facial nerve involvement may be present, and there may be progressive facial asymmetry leading to finally complete palsy. Fixity to the skin on the underlying structures, not very uncommon. And more importantly, cervical nodes may be palpable. Now let's come to this little triangle here. Deep lobe involvement, this can be seen in both the benign and malignant parotid glands. It produces an oropharyngeal bulge, which may cause eustachian tube blockade and its attendant symptoms. More importantly, when they extend to the post-styloid compartment, bear in mind that deep lobe of parotid is in the pre-styloid compartment. But when it expands into the post-styloid compartment, which is actually the neural compartment of the parapharyngeal space, it causes a whole lot of cranial nerve palsy, low cranial nerve palsies, and their associated symptoms such as aspiration, gag, loss of gag, hoarseness, so on and so forth. And that's the classic presentation which I wanted to show. So this is a tumor of the deep lobe, which is extending into the deep parapharyngeal space. It extends into the neural compartment and produces a lot of neural features also. For submandibular, for benign, most of them are non-tender, mobile, well-delineated, slow-growing masses. When malignant, they may be painful. There may be involvement of the overlying skin or the underlying structures. There may be numbness of the tongue. So there may be two nerve involvement, lingual nerve involvement, which causes numbness of the tongue, and there may be hypoglossal nerve involvement, which causes weakness or atrophy of that half of the tongue. Once again, neck nodes may be present, and they're almost pathognomonic of malignancy. So what investigations must you keep handy when you see these patients? And we can have a host of investigations, but the two important investigations are tissue diagnosis and imaging. In imaging, we look at USG, MRI, CT scan, and PET CT scan. And in tissue diagnosis, we'll look at FNAC and core biopsy. So do we need all of these in imaging modalities? Actually not. Probably USG, at the most MRI. CT is reserved for a few scenarios. PET CT is reserved for few still scenarios when you're looking at metastatic deposits within the parotid. And for pathology or tissue diagnosis, FNAC is almost the gold standard. Core biopsy is reserved for a few scenarios. I'm coming to that in the next few slides. So the advantage of sonography is that it's inexpensive, non-invasive, simple to perform. It most readily differentiates between solid and cystic masses. It provides an opportunity to stick a needle in and to get an FNAC. But the problem is that it is not comprehensive enough for assessing the deep lobe of the parotid or the parapharyngeal space. And therein come CT scan and MRI scans. All patients will not routinely require CT scans or MRI scans. When do you do a CT scan? You do a CT scan when there is suspected bone erosion, either of the mandible or at the skull base. And of course, neck nodes can almost best be assessed with CT scan. When you would do an MRI, on the other hand, MRI provides an excellent soft tissue delineation, and it will provide a beautiful plane of interface between the tumor and the normal salivary gland. I'll show you a few pictures as we go ahead in the presentation. When you have suspicion of the tumor extending to the parapharyngeal space, MRI really is the gold standard for imaging the parapharyngeal space. MRI, once again, is the gold standard for evaluating perineural spread, and this becomes very important in adenoid cystic carcinomas. So if your initial FNAC is showing adenoid cystic carcinomas, the one investigation you have to ask for in imaging is MRI scan. And once again, for recurrent tumors, because the delineation is very well understood. PET CT scan, as I said, is reserved for when you are suspecting metastatic deposits within the parotid. I also do a PET CT scan in carcinomized pleomorphic adenoma because these are extremely advanced tumors, and I want to rule out distant metastasis before I embark on a major surgery. So that's the classic, the MRI picture you're seeing. This is a pleomorphic adenoma which is extending to the deep lobe, and you can see that it is T1, it is T2 hyperintense and T1 iso or hypointense. How about fine needle aspiration cytology? Coming to pathology, FNAC is simple to perform, inexpensive, morbidity is minimal, overall sensitivity is very high, overall specificity is very high. This is level 1 evidence coming from a large meta-analysis that FNAC is excellent in differentiating neoplastic versus non-neoplastic, sensitivity and specificity in high 90s. But when it comes to benign versus malignant, the sensitivity slightly falls. And why does this happen? Because there are many benign and malignant lookalike pairs which might be missed on FNAC. So, but when you want to rule out neoplastic versus inflammatory, FNAC excellent. When you want to rule out malignancy vis-a-vis benign, sensitivity falls, but it's still in the high 80s, and you should therefore go ahead with FNAC in every case, because it can change the clinical approach in 35% of the patients. And how does it change the clinical approach? It allows better patient counseling regarding the nature of the tumor, the extent of the resection, whether you're going to do a neck dissection, and whether you are probably be required to kind of handle or sacrifice the patient now. So FNAC absolutely must be done. How about core biopsy? Core biopsy of the salivary gland lesions is a relatively new modality. I mean, it is not being used in salivary glands much too often in the past. It is more invasive, it requires local anesthesia, but in a recent meta-analysis, it has been found that its sensitivity and specificity is higher than FNAC. It yields more tissue. So when would you do a core biopsy and not an FNAC? In my opinion, core biopsy should be reserved only for 2 or 3 scenarios. And here they are. When FNAC is equivocal, to assess certain lymphoid lesions, Professor Khanna beautifully spoke about how lymphoma may be missed on FNAC, and this is where you would do a core biopsy. And when your pathologist wants additional material for immunohistochemistry, once again, you would do a core biopsy. So these are the 3 scenarios where I would do a core biopsy over an FNAC. Right, so let's look at the management. Surgery is the absolute cornerstone of management, is a treatment of choice for all salivary gland tumors. Radiotherapy can be used in 2 settings. One is adjuvant or post-operative, and second is in palliative setting, mainly for unresectable tumors. Chemotherapy is almost always used in the palliative setting. There is almost no role for neoadjuvant chemotherapy in parotid gland tumors. So if you look at the management, salivary gland tumors, benign management, they have to be excised completely with adequate margin, and never look at nerve sacrifice in benign tumor management. For parotid, the minimal surgery classically was described as superficial parotidectomy, but there is more and more evidence coming that for very small tumors, limited to the parotid and less than 2 centimeters in size, you can do something which is less than a superficial parotidectomy. And what is this? What is this surgery? This is adequate parotidectomy or extracapsular parotidectomy. Total parotidectomy, I'll come to the indications in a little while. For submandibular glands, benign, the submandibular gland resection is a treatment of choice. And for minor salivary glands, resection with a cuff of normal tissue. So let's come to individual sites. As I said, superficial parotidectomy is probably the most important surgery in parotid, and we'll also be speaking about the steps of the surgery. Classically, it's described as a minimum standard surgical procedure. It is the treatment of choice for tumors in the superficial lobe, which are not involving the facial nerve. Every effort is made to identify and preserve the facial nerve. Avoid enucleation and avoid excision biopsy because, especially in case of pleomorphic adenoma, there are pseudopods and the recurrence rates go as high as 80% when an enucleation is done instead of good margins around the lesion contributing to a superficial parotidectomy. Now, what is adequate parotidectomy? I mentioned in the last slide that there is something lesser than superficial parotidectomy which can be done. So adequate parotidectomy implies complete removal of the tumor, but avoiding capsular damage or nerve damage, and there should be a margin of at least 0.5 to 1 centimeter all around the tumors. It requires very stringent case selection. In my book, I would do this only in benign tumors arising from and limited to the superficial lobe, especially the tail of the parotid. Preferably very small pleomorphic adenomas arising from and limited to the tail of the parotid. So for malignant tumors, the goal is complete excision while avoiding unnecessary morbidity, and this would depend upon the location, size, and histology. Once again, superficial parotidectomy does come into picture even for malignant lesions, but when would you do it? You would do it only when two conditions are met. And what are those conditions? The tumor must be arising from and limited to the superficial lobe, and the tumor must be of a low or intermediate grade. So even for malignancies, a superficial parotidectomy can be done when the tumor is arising from and limited to the superficial lobe, and when it is either low or intermediate grade. Total parotidectomy is done for tumors which have extended to the deep lobe, or they are primarily arising from the deep lobe, or they are intermediate to high grade. Total parotidectomy with sacrifice of the nerve is done mainly when there is a preoperative facial nerve palsy. Or if there were no preoperative facial nerve palsy, but at surgery you find that you're leaving gross nerve on the tumor. R1 resection with maybe microscopic nerve, microscopic tumor, tumor left behind on tumor would still be acceptable. But gross tumor left behind on the tumor, on the nerve would not be acceptable, and then you would require sacrifice of the nerve. And finally, radical or extended radical parotidectomy when there is extension beyond the parotid into the mandible, skin, infratemporal fossa, into the lateral temporal bone, so on and so forth. For submandibular gland, when it is malignant, if it's small, all that you require is a submandibular gland excision. When there is large, there is a high chance of extraglandular spread, and there may be a requirement of en bloc resection, mainly of the floor of the mouth, along with the associated two nerves, lingual and hypoglossal. I often add neck dissection to my submandibular gland resections when they are malignant, and I'll come to neck dissections in a moment. For minor salivary gland, when they are sinonasal, they're usually of high grade, and therefore, when they are arising in the maxilla, maxillectomy, when they are arising in the ethmoids going to the cribriform, an endoscopic resection with good margins, or an open craniofacial resection. In the oral cavity, they're usually low grade, but once again, you want an adequate cuff of tissue, 1 centimeter of normal tissue all around it. How about management of the necks? So let's divide this into N0 and N positive. For node negative, there is no evidence to support prophylactic neck dissection. But remember, when we say N0, it's at best a clinico-radiological diagnosis. So in my book, whenever I'm operating intermediate to high-grade parotid or submandibular malignancies, I would do a selective neck dissection. And what do I mean by selective neck dissection? I mean dissection of the upper neck nodes. For a parotid, I would do levels 2, 3, and 4. And for a submandibular gland, I would do levels 1, 2, 3, and 4. So this is even in N0 necks with intermediate or high-grade malignancies. When the neck is positive, then obviously it's a no debate scenario. You're going to go ahead with a comprehensive neck dissection. And we know that in comprehensive neck dissection, modified radical neck dissection is no lesser oncologically than radical neck dissection. So here is one of the very kind of pivotal papers. It came from Armstrong, quite an old paper, but he found that for clinically positive neck nodes, more than 4 centimeters or more than high grade, the rate of for clinically negative neck nodes, the rate of occult positivity was very high. So the bottom line is, even when the neck is negative, you would do a neck clearance when the tumor is high grade or it is more than 4 centimeters in size. So that's the take home from that slide. How about adjuvant radiation? A lot of parotid tumors can go ahead without adjuvant radiation. Where would you require adjuvant radiation? You would require them in intermediate to high grade tumors, T3 and T4 tumors. So essentially all tumors more than 4 centimeters in size and which have skin involvement. Positive margins is an absolute indication for post-operative radiation. Deep lobe involvement is a plus minus. Some radiation oncologists want to give it because the resection there is often without deep margins. If the neck is positive, and if your resection specimen shows metastatic nodes, then once again, adjuvant radiation is warranted. For recurrent tumors, irradiation is warranted. Some would irradiate even recurrent tumorphic adenomas. Perineural invasion and extraparotid gland tumor extension rounds off that list. So for all tumors except T1, T2, low-grade tumors of the parotid, you're going to do an adjuvant radiation because it causes an indefinite improvement in the local region control. So for all tumors except T1, T2, and low-grade, irradiate after surgery. How about unresectable tumors? Unresectable tumors, radiation therapy is used only for palliation, And the conventional RT dose, which has been used, is 60 to 70 Grays. But there was a big study, and there have been very few randomized controlled trials in salivary gland tumors, and this was one of them. And this was the the neutron radiation therapy, and it very convincingly proved that neutron radiation has superior outcomes when it comes to salivary gland tumors. So the problem is that the availability of neutrons is very low, and it's a costly affair. But where available and where possible, neutron radiation should be preferred over photon or the conventional radiation for palliation in unresectable salivary gland tumors. Now let's come to a special scenario. How about the involvement of the facial nerve? If clear surgical margins can be obtained around the nerve, one should always prefer to, should always aim to preserve the nerve. If the clear surgical margins cannot be obtained, then you may be required to sacrifice a nerve. Whenever there are intercommunicating branches involved, very readily sacrifice them. However, always try and preserve the nerve to the eye, because this is the most morbid outcome that you can give with a facial nerve sacrifice. And in recent years, and more so in my practice, I've been using nerve stimulator in recurrent tumors or post-radiotherapy tumors to identify and preserve the nerve spectrum. How about if there's a loss of signal on nerve monitoring, or if there's a facial nerve acute injury? If there is no nerve loss, by which I mean there is no segment of the nerve lost, then you do an end-to-end neurography. Now, the technique of neurography typically was with a 8-0 or 10-0 nylon, and very few stitches, just at the 4 clocks of the clock face. But more and more these days, what is preferred is bringing the nerve in continuity rather than actually anastomosing them. So you can even use tissue glue or cyanoacrylate to bring them together. And this is a term which is known as coaptation. However, when there is a segmental nerve loss, then you will have to put in an interposition nerve graft. And the best for these are the greater auricular or the sural nerves. If there is a long-term facial nerve injury, if you get a patient who has had a long-term facial nerve injury, then all you can do is probably a mixture of dynamic and static measures. So for the lid, you can do a lid implant or a tarsography. For the mid-third, it depends upon how keen and motivated the patient is. If the patient is not very keen on surgery, all you should do is a static sling or facelift. If the patient is in good health and demands an extensive rehabilitation, then you can actually do a nerve-to-nerve anastomosis. Before I end, I'm going to talk a little bit upon the surgical details of carotid surgery. Carotid surgery is something which is very dear to me. I do a lot of carotid resections, and I've kind of developed a module for pre-op evaluation and intra-op techniques. So I'm going to briefly outline that here. Remember, they come in all shapes and sizes, so you don't have to jump into surgery. And I'm reversing that very old adage that we've often heard of. For large carotids, don't just do something, stand there and think. Now, this is an elderly gentleman who's been carrying this for a very long while. I saw him in hospital, not because he came to the hospital, but because his wife was admitted for a hernia. So once again, as I said, how do I evaluate? My gold standard is imaging, whether a CT or an MRI, and I'm always looking for the plane of the external jugular vein. So as you can see, pointed by the red arrow, that's the plane of the external jugular vein. Remember that in the carotid, the plane of the external jugular vein almost corresponds to the plane of the facial nerve. The facial nerve lies just beneath the external jugular vein, few branches, and the more proximal or the more cranial branches are actually deep to that, actually superficial to that, to the external jugular vein. So I'm looking for the plane of the external jugular vein, and that will help me understand whether the lesion is confined to the superficial lobe or it is extending to the deep lobe. Now, in the picture on the right, see how the EJV is pushed to the periphery, which means that the entire deep lobe is involved. And once again, MRI, I would prefer MRI as my treatment of choice in most carotid tumors, which are either more than 2 to 3 centimeters in size, recurrent, or they are of intermediate to high grade. So if we go to the steps of surgery, let's divide them into incisions, flaps, landmarks for the facial nerve, further dissection once you've identified the nerve, and the extent of surgery. the crux is facial nerve identification. So incision, the conventional incision is a modified Blaise incision. It has 3 parts, a preauricular part, a mastoid part, and a cervical part. Now, previously, a lot of surgeons would go a lot into the mastoid and then come back, but I prefer to give a lazy S incision. Also, my preauricular part, where do I take it depends upon if the patient has a preauricular skin crease. If the patient has a preauricular skin crease like this patient had, then I would take it in that. If a patient does not have a preauricular skin crease, then I would take it upon the surface, the anterior border of the tracheal cartilage. But you might be required to suit your to change your incision to suit the need, and it may be S-shaped incision or a modified facelift incision, or indeed excising some part of the skin. So as you can see on the left, these 2 images, a neck dissection was required. So I extended this incision into the neck for the neck dissection. And the pictures on the right, there was skin involvement. So we included a generous cuff of the skin along with that incision and extended it vertically into the neck to facilitate that incision for a good neck dissection. So the next step is flaps. Remember that the flaps have to be subplatysmal in the neck, and they have to be deep to the SMAS in the face. So subplatysmal in the neck, deep to the SMAS in the face. Once you do that, you will avoid the superficial branches. More importantly, you will avoid the gustatory sweating, which happens so commonly after peroxidectomy. The first step which I do is identify and preserve the posterior division of the great auricular nerve. You can see here that is the great auricular nerve. The anterior division goes into the parotid and is routinely sacrificed. It's the posterior division which supplies the lobule and is preserved. The next step is to identify and as far as preserve the external jugular vein. Now, in some cases, it's not possible to preserve it, and you might as well sacrifice it. But the big advantage of preserving is that you will prevent the congestion of the gland. Now, identification of the facial nerve. There are a lot of landmarks displayed for the facial nerve. Tracheal pointer is classically described as 1.5 centimeter deep, and anterior to it lies the facial nerve. Superior border of posterior belly of digastric is what I give a lot of credence to. Tympanomastoid suture line is probably the most consistent landmark, and the facial nerve lies just 0.6 centimeters inferior and anterior to it. But remember that this is a very deep landmark. So I use this landmark not for identifying the nerve, but for confirming the nerve. If none of these landmarks can be used, you do a retrograde dissection. I often use a combination of landmarks. My 2 points are superior border of the belly of the digastric and tracheal pointer. I'll come to that in a moment. So use the landmarks that are consistent and one is most comfortable with, and cross-check with other landmarks. So as you can see, that's the nerve coming out. That's a nerve coming out. And how have I identified? Sorry, that's a nerve coming. How have I identified it? I've identified it between the mastoid insertion of the posterior belly of digastric and the tracheal pointer. And these are the 2 landmarks which I most commonly use for identifying the facial nerve. For further dissection, this is done along the divisions and then along the individual branches. Be aware of variations. Almost every next parotid that you see will have variation. Round off the tissue as the nerve branches start becoming superficial close to the masseter muscle. For a total parotidectomy, finish your superficial parotidectomy first, then dissect carefully deep to each nerve branch. Don't forget the retromandibular sulcus. That's a retromandibular sulcus. Once again, that's a retromandibular sulcus. Often, this is a subtotal parotidectomy because the deep lobe extending into the parapharyngeal space is often left behind. So you can see the nerve branches have been excellently identified and completely cleared the gland here. And these are a few curios. You can see the branch of the facial nerve going to the posterior belly of the digastric. So how I do it? Step 1 is incision. Step 2 is flaps. They have to be deep to the platysma and the SMAS. Step 3 is identify and preserve the posterior division of the great auricular nerve. Step 4 is lift the parotid of the sternocleidomastoid, and this gives an excellent mobility on the parotid. Step 5 is identify the posterior belly of digastric and trace it up to its mastoid insertion. You can even add your level 2 nodal sampling at this stage. Step 6 is now go superiorly, identify the tracheal cartilage and then the tracheal pointer. Remember that tracheal cartilage is not synonymous with tracheal pointer. Tracheal cartilage is a rectangular cartilage, and the anterior inferior end of this is the tracheal pointer. Step 7, the zone of interest, as I said, between the tracheal pointer and the upper border of the mastoid insertion of posterior belly of digastric. Step 8, gently dissect layer by layer in the zone of interest. Make use of tympanomastoids which are lined to confirm the nerve rather than see it. Think of any tubular structure in this region as nerve unless proved otherwise. Step 9, you finally find the nerve, look for the silhouette, use imagination when required. Once you found the nerve, take a moment, look back at the bigger picture and then start dissecting again, and then keep on dissecting along the nerve branches. So before I end, a couple of slides upon the extent of surgery, and I spoke about it a few slides back. So diverse treatments for diverse tumors, we know that. When is there a no controversy situation? Small, definitely benign, arising from and limited to the superficial flow of the carotid, no controversy situation. Controversy arises when pathology is not definitely known. There's a benign tumor, but it is completely involving the superficial lobe, such that if you just do a superficial parotidotomy, your deep margin would probably be positive. A primary deep lobe benign tumor, a benign tumor which is involving the complete gland, or malignant tumors. So what do you have to do? You have to balance your treatment decisions. So let us tackle these. Actually, there is very low evidence, rather very few evidence to differentiate between where would you require superficial versus total. So you just have to have your own thumb rules, as I spoke to you a few minutes back. There is no level 1 evidence. There is no large head-to-head comparison of the two modalities. Most evidence is in the form of institutional cohort studies, and most of these are retrospective. When I made a literature search, I found very few results. There was only one randomized controlled trial, and this was regarding the extent of surgery, and this was limited to benign tumors. This was a randomized controlled trial comparing partial versus superficial or total parotidotomy. But there were a few caveats to this. It was a small study and included only proven benign tumors. It compared partial parotidotomy to conventional surgery. Now, what is partial parotidotomy? Partial parotidotomy is adequate or extracapsular parotidotomy, which I just mentioned. It found partial parotidotomy to reduce operative morbidity and time, but the conventional surgery group included both the superficial and the total parotidomies, and the breakup was not given. So that was a big caveat of this study. Before I end, I want to give a quick algorithm of salivary gland tumors. So if there is benign tumor, you go for a complete surgical excision. On histopathological confirmation of it's benign, you follow up. For suspicious malignant tumors, if it's surgically resectable, then you go for complete surgical resection plus minus neck dissection. I told you when you would do a neck dissection when the tumor is more than 4 centimeters in size, or when it's intermediate or high grade. You aim for complete excision. Whenever the pathology is adenoid cystic carcinoma or high grade, then you go for adjuvant therapy. If there is incomplete excision and a free excision is not possible, then you go for adjuvant radiotherapy. If there is incomplete excision at the first surgery and re-excision is possible, then you would complete your surgical excision. If it's malignant and unresectable but non-metastatic, definitive radiotherapy. If it's malignant and metastatic, palliative radiotherapy or systemic chemotherapy are the only choices. So before I end, I want to quote a very important statement, a very relevant statement from Professor Blake Caddy, and he said that in the realm of surgical oncology, biology is the king, selection is the queen. Technical maneuvers, which means all the surgeries and all the surgical interventions that we do, are just the prince and princesses. Occasionally, the prince and princesses might try to overthrow the king and the king, sometimes with temporary and apparent victories, but usually to no long-term avail. It's only the biology and the case selection which eventually prevails. Thank you so very much.
So, chairpersons, Dr. Dharmesh is already 10:15. I would request both of you to take the questions in the chat box, and Dr. Abhishek can answer them directly to the delegates who are answering in the chat box itself, so that the third speaker can start his talk in time, you know. Dharmesh, you are muted. Unmute yourself.
Hello, am I audible now?
Yeah.
Hello.
Abhishek, that was a excellent talk comprising everything about the salivary gland. Congratulations. Because of shortage of time, please excuse us for taking the questions on the chat, if you don't mind.
I'll answer them, sir. Thank you.
Thanks a lot. Dharmesh, over to you.
Yeah, over to Gautam Goyal. He will introduce Dr. Shyam Thampi.
Sure. Sure. Our next speaker is someone who's extremely important to us as a surgical team, our physician counterparts. Dr. Shyam Thampi is basically an MD and a DM pulmonologist. He's done his MBBS and MD from AFMC Pune and then his DM from PGI Chandigarh. He's been a former surgeon captain and head of the Department of Pulmonology at the Naval Hospital, Colaba, Mumbai, and a former professor and senior advisor in the Army Hospital. He's also been a former honorary faculty and unit head at the Department of Medicine at Grant Medical College. And he's also been a former undergraduate and postgraduate teacher and examiner for the MUHS. He has a number of publications on his to his credit and number of memberships and fellowships as well. Can I please call upon Dr. Thampi to take the session on tuberculous lymph nodes?
Yeah, thank you, Dr. Gautam, for that few kind words. At the outset, I am grateful to the Mumbai Surgical Society and in particular to the President, Dr. Niranjan, and Dr. Ajay for giving me this opportunity to share my views on the management of cervical TB lymphadenitis. So we know that TB lymphadenitis is a chronic specific granulomatous disease and inflammation of the lymph node with caseation necrosis caused by infection with Mycobacterium tuberculosis or related bacteria. The characteristic morphological element is the tuberculous granuloma, or what is known as the caseating tubercle. Now, when it goes on to involve multiple lymph nodes like this, then we often refer to it as scrofula, and it can result in such disfiguring sinuses and discharge from all over the neck, as you can see in this ill-fated boy. So an overview, it is the commonest form of extrapulmonary tuberculosis with vivid clinical manifestations and resulting from multiple and complex and variable pathogenetic immunologic pathways. The epidemiological characteristics differ from the pulmonary tuberculosis. Diagnosis may be challenging and management may be far from satisfactory. Multimodality treatment options are frequently required for successful management. A brief look at the historical perspective. As early as 2700 BC, lymphadenitis was cervical lymphadenitis has been mentioned in Chinese literature. Hippocrates made a note of this in 460-377 BC. Incidentally, in 300 BC to 620 AD, there is mention of a Kant mala in the Indian literature, indicating the cervical lymphadenitis. And it was in 936 to 1018 AD that Abdul Qasim al-Zahrani discussed surgical excision of these lymph nodes for the first time. In 1786 to 1851, Jean Lugol came upon the iodine solution treatment for these lymph nodes, probably not very successful. And early in the 20th century, the surgical excision was planned. Now, in 1937, Griffith came to the conclusion that 50% of cervical adenitis was due to Mycobacterium bovis. In 1950 to 70, a lot of anti-tubercular drugs treatment plus various surgical procedures were combined for effective treatment. And it was in 1975 that 75% isolates of adult lymph node tuberculosis yielded Mycobacterium tuberculosis. So tubercular lymphadenitis is a peripheral lymphadenitis, previously termed as scrofula, is a unique manifestation of disease due to organisms of the Mycobacterium tuberculosis complex. Now, current imaging modalities have dramatically altered management of deep TB lymph nodes. Epidemiological characteristics differ from those of pulmonary tuberculosis and clinical manifestations are variable. The diagnosis may be challenging and treatment may be frustrating often. A brief look at the epidemiology. Worldwide, including Western countries, the proportion of extrapulmonary cases with their principal subset, lymphadenitis has increased. In low TB burden countries, the majority of patients are foreign born with a pattern consistent with reactivation disease. In the USA, 95% of adults have Mycobacterium tuberculosis, whereas 92% of the children had non-tubercular mycobacteria. Immigrants from Southeast Asia and India appear to have a special predilection for tuberculous lymphadenitis, particularly in US, Canada, and Britain. Africa may also have an increased risk of lymph node tuberculosis. The basis for enhanced risk among women in Asians and Africans is not known. Possible host factors include occupations or cultural practices favoring oropharyngeal exposure to MTB complex, genetically determined organ tropism, hormonal influences, effects related to the BCG immunization, and differences in health-seeking behavior. Now, I think we are all familiar with the levels of cervical nodes, but for the sake of our younger colleagues, the residents, just like to touch upon the levels so that when we go on to discussion further, we know what we are talking about. So the level 1 is the submental group that is here within the triangle bounded by the anterior bellies of the digastric and hyoid bone. Submandibular glands are bounded by the posterior belly of the digastric and body of the mandible, as you can see here, right? The level 2 are the upper jugular, around the 1/3 of the internal jugular vein and adjacent spinal accessory nerve, extending from carotid bifurcation to skull base. Level 3 is the middle jugular, that is here, right? You can see the marking around the from carotid bifurcation superiorly to the cricothyroid membrane inferiorly. Level 4 are the lower jugular nodes. They are around the lower 1/3 of the internal jugular vein from cricothyroid membrane to the clavicle inferiorly. Level 5 is the posterior triangle, that is here. That is the posterior triangle. And along the lower half of the spinal accessory nerve and the cervical artery. Supraclavicular nodes are included in this group. Posterior border is the anterior border of the trapezius, and the anterior boundary is the posterior border of the sternocleidomastoid. The level 6 is the anterior compartment group from hyoid bone superiorly to suprasternal nodes inferiorly. Lateral boundary in each side is medial border of the sternocleidomastoid and consists of the pretracheal, paratracheal, prelaryngeal, and precricoid nodes. Level 7 nodes often are referred to the anterior mediastinal group in the tracheo-esophageal group. So, lymph node tuberculosis and their relationship with HIV and diabetes mellitus. Extrapulmonary tuberculosis, including lymphatic tuberculosis, is more common among immunocompromised patients, including those with HIV infection. Although diabetes mellitus is a risk factor for pulmonary tuberculosis, studies suggest that it may reduce the relative risk of tuberculosis lymphadenitis. Anti-tumor necrosis factor alpha diagnostic therapy, antagonistic therapy may lead to TB lymph nodes. This anti-TNF therapy we use in various rheumatoid arthritis, etc., or collagen disorders, sometimes may lead to TB lymph node infections. Mycobacterial tuberculosis is the usual cause of tuberculous lymphadenitis. Other infectious causes of chronic lymphadenitis include the non-tubercular mycobacteria, including the Mycobacterium avium, Prophylaceum, etc., the Pseudomonas pseudomallei, Toxoplasma species, the Bartonella, and various fungi. Here's a typical histopathology of a tuberculous granuloma, where you can see this is the granuloma. This shows the granuloma here, and it consists of the epithelioid cells, the multinucleated giant cells, and the caseous necrosis within, and infiltrated all around by the lymphocytes. This is what a typical tuberculous granuloma looks like. Clinical features usually present as a slowly progressive painless swelling of a single group of lymph nodes. The duration of symptoms at the time of presentation is typically 1 to 2 months, varying from 3 weeks to 8 months. The mean duration of symptoms is usually longer in men than in women. And here is a simple algorithm just to show the lymph node, TB lymph node progression. Granuloma, from there, the solid caseous tissue goes on to a tubercular bacilli which are dormant, and the persistent lymph node tuberculosis there. If the solid caseous tissue gets liquefied, then it goes on to form a cold abscess. The therapeutic agent that reduces the amount of liquefaction would be of considerable help in these places. Tubercular bacilli multiply logarithmically and in extracellular environment, reaching in tremendous numbers. Brief look at what the stages of cervical TB lymphadenitis is. The stage 1 is the firm, enlarged, mobile, discrete nodes. There is lymphoid hyperplasia with formation of tubercles and granuloma. In the stage 2, there are large rubbery nodes fixed to surrounding tissue due to the periadenitis, which is classical of tubercular pathology. And there is the caseation, which starts here. In the stage 3, there is central softening due to abscess formation, and there is progressive caseation necrosis. In stage 4, as you see, the typical collar stud abscess, okay, where the majority of the lymph node and the abscess is below the plane here, and it starts moving outwards, and the skin over is inflamed, and there could be a rupture of caseous material. In stage 5, there is sinus tract formation with discharge onto the skin. Symptomatology. Patients do not generally report significant pain at the presentation. So it's basically painless lymphadenopathy. No tenderness during examination noted only in about 10 to 35% of cases, as against an acute lymphadenitis, which could be an infective or inflammatory cause. A draining sinus may be present in 4% to 11% of the cases. The unilateral involvement of 1 to 3 nodes has been noted in 85% of the cases. Cervical chain involvement is most common in 45 to 70%, with 12 to 26% in the supraclavicular region, and 20% cases are bilateral. HIV infection has been presumed to be responsible for the rise in number of tuberculous lymphadenitis cases. Clinical manifestation depends on the CD4 count. More than 250 CD4 count, the granuloma or caseation necrosis, very plus minus acid-fast bacillus seen. Less than 200, there is poor granuloma formation and AFP become more prominent. Less than 100 CD4 count, there is an acute pyogenic abscess, and it's teeming with acid-fast bacilli in these lymph nodes. Now, lymph nodes in TB in HIV seronegative patients. What about them? There are several studies which have been done. The site of involvement is classically cervical, axillary, inguinal, multiple sites in the order of involvement. There's almost 86% in this study. Most of them show 94, 93% cervical lymph nodes. And the physical findings are matting and fixity, discrete nodes, abscess formation, sinuses, and often ulcers. A definitive diagnosis of a tuberculous lymphadenitis can be made by culture or polymerase chain reaction demonstration of MTB in an affected lymph node, thereby permitting distinction from other mycobacteria that may cause lymphadenitis. As Dr. Khanna had mentioned in his talk, ultrasound is an excellent first-line investigation as it assists the cervical lymphadenopathy and also enables guided fine needle aspiration cytology. Differentiating features from neck metastasis include nodal matting, surrounding soft tissue edema, homogeneity, intranodal cystic necrosis, and posterior enhancement. These are some of the features that differentiate from a metastatic node. The Doppler examination is particularly useful in helping to distinguish tuberculous infection from necrotic metastatic disease. Reactive nodes, including those in tubercular adenitis, demonstrate prominent vascularity, but mostly confined to the hilum whereas malignant nodes demonstrate more peripheral or vascular or capsular vascularity. As you can see here, this is what the lymph nodes look like, and just below the clavicular and the sternal head. There's another picture of the scalene nodes, and this is the internal jugular vein, and you can see the large lymph node there. Dr. Khanna also touched upon the CT scan appearances, and I would like to re-emphasize that the appearances of TB lymphadenopathy is variable depending on the degree of caseation. Nodes may initially appear merely enlarged, often with attenuation similar to muscle. Eventually, central caseation develops and the nodes become centrally low density and eventually frankly cystic. They are usually matted together with only minor surrounding inflammatory changes. And you can see that here. Here's a large lymph node with necrosis within, forming almost cystic spaces in this CT scan picture. The MRI appearances are similar to those of CT scan, ranging from homogeneously enlarged nodes to cystic transformation with peripheral enhancement. The PET CT was also touched upon. Is an important non-invasive diagnostic tool. The enlarged FDG18 lymph node having standardized uptake of SUV of less than 5 are diagnostic of tuberculosis. It is more useful in detecting reactivation of lymph node TB during immunosuppressive diseases like HIV, cancer, etc. Serial decline in SUV is useful in monitoring drug response, and metabolic response may indicate clinical response and guide duration of antitubercular treatment. We use nucleic acid amplification test like the CVNAT, that is the cartridge-based nucleic acid amplification test, which is a rapid, specific, and sensitive means of diagnosis. The Gene Expert, what we call, or the Gene Expert Ultra, which is available now. A systematic review of these in tuberculosis lymphadenopathy revealed highly variable, inconsistent results, sensitivity all varying from 2% to 100%, and specificity of 28% to 100%. But as we have become more and more knowledgeable, and we have moved on from Gene Expert to Gene Expert Ultra, we have now, we can detect from a smear which detects something like 10,000 bacilli need to be present to be picked up in a smear, whereas in a Gene Expert conventional, which we were doing till now, we needed about 133 odd bacilli. And with Gene Expert Ultra, we can detect even a sample with up to 16 bacilli. So you can imagine the rapid advances in our molecular techniques. This is the newer diagnostic techniques like nested PCR and smear PCR, and their positive predictive values. As you can see, many of them are in the sensitivity and specificity, you can see, are in the 96% here, 93%, 96%, and so on. As compared to the conventional methods of Zeren smear, Nielsen, MTB culture, and cytology and histopathology, up to 62%, whereas these can pick up almost 93 to 96%. Yes, there was a little discussion about excisional biopsy, and is the most invasive approach to diagnosis. However, it has the highest sensitivity and may produce a more rapid and favorable symptomatic response, and has been recommended in cases involving multiple nodes. Complications of biopsy include post-surgical wound, pain, wound infection, sinus formation, and scar. As mentioned earlier, FNAC is the first-line diagnostic workup which must be done technique, so especially in tuberculosis endemic countries where the test is both sensitive and specific. FNA is safer, less invasive, and more practical than biopsy, especially in resource-limited settings. And the yield can be as high as 48 to 83%. The FNAC technique, I won't go into it, but basically, as was discussed earlier, a 5 ml syringe with 18 to 21 gauge needle. All you need is 3 microscopic glass slides, and holding the gland between the thumb and index finger, right in the center of the node, where maximum fluctuation, pull back on the syringe, and if no aspirate obtained, move the needle in both directions while gently compressing the lymph node. Culture, however, remains the gold standard for diagnosis, but may take 2 to 4 weeks to yield results. A positive acid-fast bacilli stain result indicates a mycobacterial etiology and has excellent specificity for MTB in adults. The following histopathological features support a diagnosis of probable tuberculosis in AFP negative, culture negative cases. For example, non-specific lymphoid infiltrates, as I showed you in the histopath photo that I had shown, non-caseating granulomas, and Langerhans giant cells, Langerhans giant cells in areas of extensive necrosis. These go more in favor of histological features which support a diagnosis of probable tuberculosis. Of course, ancillary diagnostic tests need to be done. We all get a MANTU done or a tuberculin test. And these days, the interferon gamma release assays are being done. But these are highly sensitive, but not so specific for the disease. The drug treatment, we know that the conventional 6 to 9 months of treatment with the first-line drugs, isoniazid, rifampicin, pyrazimab, methimbrolol, followed by isoniazid and rifampicin for another 4 months. Now, one does depend on the progress of the individual, on the lymph node size, the appearance and the dryness, that the duration of the therapy may extend from 6 to 9 months based on the individual response. However, the relapse rates are almost the same in both. However, when we have a lymph node that is not responding and where we have resorted to a culture which shows possibly a resistant organism, there it may be we need to get a drug susceptibility testing done on those patients and go in for second-line AKT or third-line AKT depending on the type of multi-drug resistant tuberculosis that you have. Now, possible mechanism for the beneficial effect of corticosteroids which are given along with the ATT. The adjunctive use of corticosteroids in TB may have an anti-inflammatory effect, inhibitory actions on the release and activity of lymphokines and cytokines leading to rapid regression of lymph node size and obviate potential complications, directly suppress the pathological effects of cytokine tumor necrosis factor and from activated CD4. Even in rifampicin containing regimen, significant clinical advantages observed, and they also prevent paradoxical reactions in them. Many of us have been practicing the intra-lymph node injection of methylprednisolone, and they are practiced in these kind of the size of lymph nodes and the amount injected, and at interval of 2 weeks, a maximum of 3 doses, followed up fortnightly, and shows a 50% size reduction in the lymph node. And in this particular study, they showed a complete regression in 83 patients. That is about 24.85% of the patients who were studied. Now, often we get paradoxical upgrading reactions. What are these? These are worsening of symptoms during treatment. That is a paradoxical upgrading reaction. One definition is the development of an enlarging node, new nodes or a new draining sinus in a patient who received at least 10 days of treatment with antitubercular drugs. This has been reported in 20% to 23% of HIV negative patients. We're not talking about the inflammatory syndrome that is observed with TB and HIV. We're talking about HIV negative patients who show these upgrading reactions, paradoxical upgrading. It occurred at a median of 1.5 months. Manifestation of the PUR have included enlarging lymph nodes, new nodes, pain in 60% or draining sinuses. In addition, increased adenopathy has also been reported in 9 to 11% of patients in a mean of 27 months after successful treatment. So flow diagram to show the possible mechanism of adverse events during effective ATT. Successful chemotherapy, there is rapid mycobacterial killing, release of mycobacterial products, production of TNF-alpha, various interleukins and other cytokines, there is local inflammation, necrotizing and caseous reaction, increase in size of lymph node, appearance of new cold abscesses or cholesterol abscess formation. This is the mechanism of the inflammatory or upgrading reaction that we see. Biopsy or culture of nodes involved in the upgrading reaction paradoxically typically shows granuloma formation and negative culture results with or without positive ARV stage. Steroids have been considered as a means to reduce the robust immune response in PUR, but their use is controversial. Intralesional, intra-lymph node injection of depot methylprednisolone averts most of these if given at earliest warning signal. Surgical therapy, you all are experts. I will not be able to guide you, but however, the guidelines recommend surgical excision only in unusual circumstances. For patients who have discomfort from tense fluctuant lymph nodes, for paradoxical upgrade reactions, as an adjunct to antibiotic therapy for disease caused by drug-resistant organisms, and cervical lymphadenitis due to non-tuberculous mycobacteria. So here is a study done in Queen Mary Hospital, University of Hong Kong, where they studied, the effect of total excision versus, that is the under GA, abscess wall plus adjacent deep-seated lymph nodes were excised, primary wound closure, versus incision and drainage. And wounds are kept open for drainage. And you can see that the excision showed almost a residual lymph node of 17%, whereas in the incision group it was 18%. It's almost similar with both the patterns. Now, a word about the non-tubercular mycobacterial lymphadenitis. Most common is the Mycobacterium avium complex. Then you have the Scrofulaceum and the Kansas-C and others. Usually, these are unilateral and non-tender. Submandibular and submaxillary glands may be affected. Cervical or preauricular lymph node in young children of 1 to 5 years of age. Truly localized disease. And 92% of US children have non-tubercular mycobacterial disease, as I mentioned earlier. In Australia and Canada, there are much more of NTM than in other places. The mycobacterial adenitis caused by non-tubercular mycobacteria, such as avium complex, is typically seen in non-BCG immunized children in developed countries. The diagnosis is simple diagnostic biopsy. FNAC is controversial. Skin tests with NTM antigens and NTM antigen specific gamma interferon. Treatment of NTM adenitis is surgical and achieves cure rate of 70%. What about lymph node TB in children? It usually comes through the lung route or tonsillar route. And in recent and acute infection, there's a greater degree of periadenitis. Later or sooner, lymph node softens and forms abscesses. Anti-gravity aspiration, which is normally advocated, just delays the process and may lead to sinus formation here. A majority of lymph node tuberculosis is a regional component of primary complex rather than result of hematogenous dissemination. A word about BCG lymphadenitis. Most common complication of BCG vaccination. 2 forms of BCG lymphadenitis can be recognized. The simple or non-suppurative adenitis usually regresses spontaneously. Suppurative BCG adenitis is distinguished by the development of fluctuations in swelling with erythema and edema of overlying skin. The diagnosis is there is a history of BCG vaccine, absence of tenderness and raised temperature over the swelling, absence of fever and other constitutional symptoms, and most of the diagnoses are corroborates with the clinical diagnosis in doubtful cases. There is no role for antibiotics or antitubercular drugs. Needle aspiration recommended for suppurative BCG lymphadenitis, prevents discharge and associated complications, shortens the duration of healing. It is safe. Surgical excision, useful in cases with failed needle aspiration, multiloculated or matted lymph nodes and draining signs. Non-suppurative BCG adenitis is a benign condition and regresses spontaneously without any treatment. So, ladies and gentlemen, I would like to conclude that lymph node tuberculosis is the commonest form of extrapulmonary TB with vivid clinical manifestations. Epidemiological characteristics differ from pulmonary tuberculosis. A high index of suspicion on the part of the clinician is a must. The diagnosis may be challenging. However, with the help of MTB gene expert and MGIT, culture of lymph node aspirate helps in clinching a firm diagnosis. The management may be far from satisfactory. Multimodality treatment is often required. A good FNAC, needle biopsy, ZN staining, and Mantoux test and ESR make diagnosis in almost all the cases. And optimal management of comorbid conditions must be made along with the treatment of lymph node tuberculosis. The lymph node TB may enlarge during ATT or appear afresh, will eventually respond to treatment. Development of fluctuation requires immediate attention and early surgical intervention. Residual lymph nodes at the end of ATT should be closely monitored. Thank you for a patient hearing.
Thank you very much, Dr. Thampi. That was absolutely an extensive talk covering every little factor. In fact, there were certain questions as a surgeon which we had in our mind, basically about the paradoxical upgrade in the symptoms of the patient and enlarging lymph nodes and things coming back, but you addressed it extremely well. If I could just take one or two questions on this with Dr. Khanna over here. Dr. Khanna, are you able to hear me?
Yes, sir.
Hello?
Yes.
Yeah, Dr. Khanna. Yeah, I just wanted to ask you one thing. When a patient with tuberculous lymphadenitis reaches you in this very specific situation of having a draining sinus, what is your timing of surgery? Do you start AKT, then excise? You start AKT, watch for closure. You think about excision after a month or so of AKT. What do you decide to do, and what would you suggest we do, Dr. Thampi? Both of you all.
I think in any type of the tuberculosis which is there, it's always first the medical treatment. So whether it is a lymph node or whether it's a sinus or it's a abdominal cocoon is there or intestinal tuberculosis is there, anything. So you have to start with the anti-tubercle treatment. See that what is the response of that. Like if the tubercular sinus is there, almost about 2 to 3 months treatment, I will say about 70 to 80% sinuses heal by your 2 to 3 treatments on the ATT. So you do not require to carry out any surgery. But if it is a persistent one, it is not responding to the ATT, you may add some antibiotics to that, levofloxacin and all those things can be added to that. You will get still a little more better response. But still, if it is not responding, then I will think of the surgery. But I will like to avoid the surgery in this patient. Yeah.
Yes, I think I only have to add to that. I think sir has summarized it very beautifully. And I think I would avoid surgery as far as possible, and because we have such good drugs at our disposal now. And if they are given in the proper dosages, in the proper duration, you have miraculous results with most of the drugs. Even as Dr. Khanna has mentioned, the sinuses heal within 2 to 3 months, and the discharge stops completely, the lymph node shrinks, and there is absolutely no indication to go in for surgery unless you've given a complete therapy for at least 3 months. Having said that, if you have a multi-drug resistant situation where despite giving your second line and third line drugs to these patients and you still have a bulk of the disease, then I would probably use surgery to my advantage to remove the bulk of the disease and maybe remove as many lymph nodes and take the risk of a persisting sinus or something like that, which would probably most often heal with good medical therapy following the removal of the bulk of the disease.
So I guess a very, very strong message here is probably that it is purely a medical disease and we surgeons should intervene with a lot of caution in this situation.
One small query. Those patients who are HIV positive, do we wait for a longer time for the AKT before we decide to go in for surgical action or any residual disease?
Yeah, actually, sorry, sir. Sorry.
Yeah, please carry on here. Please carry on.
Sorry. No, I would wait. If we are giving both AKT and ART in a patient of HIV, one has to be, vigilant about the inflammatory reactions that you often have in these patients, because of starting ART and the sudden improvement in the immunity. So you will probably find new lymph nodes coming up. You will find new sinuses coming up. These upgrading reactions, as you see, much more seen in the HIV positive people who are given. So you need to cover that stage before you go on to a surgical thing. In fact, one of the indications is when you have that kind of a uncontrollable reaction, then you can advocate some surgery to remove some of those lymph nodes and get a grip on the sinus discharge.
But the standard regime is that you give AKT for 6 months At the most, you give it for 9 months. But in HIV positive patients, you probably would like to give it for say 12 months or maybe 18 months before you think of.
Oh, no. HIV positive, they heal as good as non-HIV, provided they are compliant to therapy and you monitor it. You do not need to extend the therapy of antitubercular therapy beyond what you would give in a normal individual. Because if the lymph nodes have regressed, the sinuses have healed, they have fairly good results. By giving 9 to 12 months or 15 months, no, you don't need to extend it. That is in the case of an MDR TB that is not responding to the first line in first 3 months of therapy. Then we need to reassess, look at the lymph nodes again. But now that situation doesn't arise, because that is why right at the upfront, we tell the surgeon, do an excision biopsy so that we can send it for MTB gene expert, and not only get a confirmation, rifampicin resistance also can be got in just the gene expert. As soon as you get the gene expert, you also got rifampicin resistance. That gives you a guidance whether this is a MDR, likely to be an MDR, or it is a sensitive tuberculosis. If you go ahead and do the MGIT culture of a portion of that lymph node, you will get your results within 3 weeks, 3 to 6 weeks, and a DST. And if you get a drug sensitivity testing and you know the drugs are not going to respond to those particular first line drugs, you need to be guided by the DST, the drug susceptibility test, to plan your chemotherapy for the particular individual.
But because of most of the lymph nodes involved in tuberculosis are positive bacillary, the culture negative incidence is quite high in lymphadenopathy because of tuberculosis.
Yeah.
Now, how do I guide myself?
Yes. So that is why the paucity of bacillus is an important issue. But as I mentioned, that nowadays we are doing things like Gene Expert Ultra, which picks up 16 bacilli, as I told you. Whereas in a smear, you need 10,000 bacilli. 10 to the power of 4, 3 and 4. Whereas in a Gene Expert Ultra, which we have, 16 bacilli is all you need, 15.6 to be precise, to pick up a positive lymph node. And you also get the information regarding the MDR, RIF resistance is there or not. And if RIF resistance is there, you're dealing. Within 2 hours, you can have this report. Within 2 hours. So I would, my advice would be that we must go in as wherever possible to get MTB Gene Expert Ultra done in wherever it is available, and also simultaneously send it for an MGIT culture.
Okay.
I would just like to reaffirm Dr. Shyam what he said. There is no difference in the treatment of the tuberculosis, whether it is HIV positive or it's HIV negative. The type of the drugs and the duration of the treatment which is there is the same as that in the HIV negative patient. So that message should be taken.
Dr. Thampi, I would like to ask you 2 questions. One is, as I mentioned at the beginning, every patient of tuberculosis lymph node which comes to you, whether you would take it directly as an MDR and do cultures and gene expert in every patient, or if the FNAC is positive, you would start with anti-tuberculous treatment. Second, whether you would advocate giving a short course of steroid in all these patients, or only if there is a paradoxical reactions.
Very important and relevant question, sir, and management issues. Now, I would recommend that when you diagnose a lymphadenopathy and you feel clinically it is a tuberculous lymphadenopathy, an FNAC need be done, and if possible, get a core biopsy or an excision lymph node biopsy. That is what I would say. These days, you can get a core biopsy, which can also be sent for Gene Expert and MGIT culture. You may not need to do a excision biopsy in all the cases.
But that should be done in every case. That's what you are advocating.
I am advocating that it should be done because you get all the information within a day or 2. And if you have that much information within a day or 2, you can change the course of the treatment, change the course of the disease altogether. If you know that you're dealing with an MDR TB upfront, I have a gene expert which says that this is MTB tuberculosis detected, and I have a RIF resistance present. I straight away know that I'm dealing with an MDR TB. I don't need to exhibit this patient to the first line AKT. It's not going to help, or rifampicin or INH for that matter. So I might as well go in for the injectable second line drugs or fluoroquinolones as we plan the therapy and second line and third line drugs for these patients. So I would say that you must go in upfront.
So that means there's no role. That means there is no role for FNAC. One should send directly for a core biopsy. What is the point in pricking the patient twice?
Yes, absolutely. If you have the option, go in for a core biopsy. If you don't have the option, you're in a peripheral setup, a primary healthcare, obviously an FNAC is all that you can get.
And then you can do an excision. Even primary center also, excision and local can be done.
Can be done. There I would resort to an excision biopsy.
In that case, FNAC should be absolute now.
Absolute. No, by itself, it is obsolete as far as correct management of scientific management of tuberculous lymphadenitis is concerned. I would not say that go by FNAC.
What about the steroids?
Niranjan, biopsy should not be taken very casually.
Yes, sir.
It should not be taken very casually.
But a core biopsy can be done these days.
No, but the core, even if you're doing a core biopsies, you have to put your needle at least 1.5 to 2 centimeters in the depth.
Yes, sir.
And majority of these lymph nodes are in the lower, in the supraclavicular regions. And in supraclavicular region, there are so many vital structures which are there. All the blood vessels, all the nerves, the thoracic duct, and all those things are there. And there are definite reported complications along with that. So I think it should not be taken very lightly. If your work can go only with the cytology only by doing the FNAC, you go ahead with that. And I think if there is a first time lymph node which is appearing, it should not be taken as MDR tuberculosis. Okay, but if the patient family history is there or there are other problems which are there, then you may think about that and go for the gene expert and all those and look for the rifampicin resistance which is there. So still that is my, and I think, almost all the speakers, they have said that first thing should be the cytology. Doing FNAC is very easy, least traumatic. Immediately within 1 or 2 hours, you get the results of that and you can start your treatment. If you are doing a biopsy, it is going to take at least 5 to 7 days to get the biopsy report of that. Definitely you can do all the other markers which are there. But if your work satisfies only with the FNAC, I think that should.
What about the steroids?
I have a couple of questions to ask over here. One is
he has to answer the steroid.
Gautam, one question about steroids. That whether steroids should be given in every case of lymphadenitis. Well, it depends on the periadenitis which you see. If there is excessive inflammatory reaction in these patients, and that is where a biopsy plays a major role. It will tell you that there is a lot of inflammation. And if that is so, then steroids may be given. Or in a setting where the patient is, the skin is almost, stretched to the extent that it's about to rupture or something like that. The inflammatory reaction is so violent. So when there are these groups of lymph nodes, then it is better to give them a small course of steroids, and that will help to reduce the inflammation and settle the lymph nodes. This is what I would do in a cervical region, sir.
I think the role of the steroids, which is there, it is like the patient is having the tuberculous peritonitis is there, with a lot of adhesions which are there. A patient having the tubercular meningitis is there, and you think because of the adhesions, there will be a problem. And there is the least role of having the steroid for a simple tubercular lymphadenitis. It is for the other reasons which is there, which are going to cause real problem to the patient. A patient may go into a recurrent obstruction because of the adhesions in the abdomen. The patient may have the meningitis because of that. There probably is the role of the steroid, not much in the case of the cervical lymph.
There is one query in the chat. It is asking, how does one treat recurrence?
Recurrence of
yes, TB lymphadenitis. Patient has been given a full course of AKT, there is complete regression, and then patient comes back with a recurrence. Is it to be treated as a fresh case, and how long do we wait before you label it as a recurrence and not just a part of the PUR?
From experience, what we have seen is when you treat a patient of cervical lymph node tuberculosis with conventional AKT in a compliant fashion, in a compliant patient, adequate duration and dosage being given, and the patient responds very well. Usually there are not many recurrences and relapses. But if we see a relapse, it usually happens in the first 6 months to 1 year, in which case you call it a relapse. But however, beyond that, relapses are quite unusual. But we have seen patients who come, after a year or 2 years, they come back with another lymph node, not in that area, but somewhere else. And maybe a third time you have to treat. I've treated a young lady for 3 times in the same lady, but I never gave up. I kept altering my chemotherapy, the drugs, the drug combination, and based on the, it was an MDR. So, I mean, I knew that I was dealing with a very difficult situation. So I had to get the excision biopsy. I had to get the culture done. And that is where it helps in these difficult cases to type the kind of infection that you've got, organism. Is it a drug-resistant organism or is it not? And if so, which drugs are going to be effective and which are not going to be effective? So for a person coming for the third time, you can imagine how frustrating it is both for the patient as well as the doctor for the third time. And in a lady with a pretracheal lymphadenopathy. So something like that. I mean, it shows up every time it comes. And a young lady, so you can imagine. So it can be quite traumatizing for the patient and for the doctor, third time treating the same place, because the patient, fortunately came back to me. Which patient would come back to you for a third time? They probably find somebody else and go. They say, yeah, you take me what over the Vaidya take me what, but it's not so. It happens. Recurrences and relapses do happen, but we don't give up. We again type them properly, approach it scientifically, and treat them. And given the duration, the lady is free of disease for the last 5-7 years now. She hasn't come for follow-up with any relapses or recurrences.
We'll probably take the last question over here. There's one more on the chat box, which says, any comments on Kikuchi's disease?
Oh, Kikuchi's disease is quite different from TB lymphadenitis, but I guess it also presents in the neck. So it is a confounder and a differential diagnosis for lymph node tuberculosis. But unlike Kikuchi's, which will show a reactive kind of lymphadenitis when you do a FNAC or a lymph node biopsy, whereas in a TB lymphadenitis, there's a lot of caseation. There's a lot of a possibility of granulomas, epithelioid, and acid-fast bacilli may often be detected in these patients. So Kikuchi is a confounder and should not be taken for granted, but one has to be alert that is why an excision biopsy is so important, to put it through all these little things. So where you have a choice, do an excision biopsy, particularly when you are not clear. FNAC will definitely give you something, but if it says reactive lymphadenitis, where are you?
That's right.
Pathologist says reactive lymphadenitis and throws it back at you. So where do you stand now? Do you go for a biopsy? Do you go for a FNAC? What do you do now? So therefore, in those difficult cases, that we go ahead and ask for a excision biopsy upfront to do all these tests and type it properly. If you make a good start, you'll have a good finish. That's what I believe.
So that was actually going to be my last question to you. When we get an FNAC which shows us something like reactive lymphadenitis, do we stop there, or do we actually then go ahead with a formal biopsy to get our answers?
Oh yes, if you are not convinced, for example, physicians, if I'm not convinced that, look, this is not fitting into the picture for the work the patient has come to me with. This does not look like a reactive lymphadenitis. I mean, it's Cox. I mean, we have an Xray to show maybe mediastinal lymphadenopathy as well. We have a MAN2, which is 22 to 25 millimeters positive. You have IGRAs if some people come in with the TB Gold test, which showing highly positive and all that. So you have these supportive evidences.
Right.
We don't go with just one thing, And so if you get a reactive lymphadenitis there, then you have every reason to suspect that, no, something is wrong. I need to go in for an excision biopsy, Whereas in, unlike in Kikuchi's, in tuberculosis, you have caseating granulomas, which are very, very classical, and histopathology is absolutely mandatory in such cases. Kikuchi is not an easy diagnosis to make, let me tell you, because Kikuchi can be made only when you have excluded all these other possibilities.
That's right.
There are some
That is the
criteria
cause.
which say that if the size of the lymph node, the length is more than 1 centimeter, then it is to be considered as significant and it should be chased. It should not be left alone.
Absolutely.
I
Absolutely.
mean, the axillary lymph node is more than 1.5 centimeters. But in
Right.
case of neck node, the size is less because
More than 1
it needs to be
centimeter should
changed.
be taken as significant. Absolutely, sir.
And
Absolutely.
especially
think
the
we
lower
should wind
cervical.
up.
If it, the lower cervical is there, you have to be more cautious about that.
I
If the
think
upper
we should
cervical
wind
is
up.
there, you can think.
Supraclavicular especially supraclavicular is the most dangerous one.
And that is why you require a quadruple assessment for the neck swelling. So you have to be sure on the clinical grounds that you are dealing with not just a reactive lymph node, but it is something else.
Yeah,
So
because
thank
if you're
you.
going to ask for a USG guided FNAC, then you have to be sure that the size or the length is more than 1 centimeters. That is significant. So you're
Thank
asking
you,
for an AML
chairpersons. Thank you, chairpersons. It is 11:05 now. It is a very common topic, and that's why so much of interest is generated.
Yes.
We can go on and on. I know that, but time constraints have to be followed. Thank you so much, both the chairpersons. You have done an excellent job in moderating the sessions today. And needless to say that the speakers were expected to do a very high quality job because they were meant for that. And thank you for obliging us. You did great justice to my delegates who have logged in. So thank you, Dr. Khanna, Dr. Abhishek, and Dr. Shyam. Thank you very much. Thank you, Juventus, for yet another session. And see you next Friday. Thank you all.
And very good
Thank you, sir. Thank you.
selection of
Thank you.
topics by
It's
Dr.
such a pleasure.
Niranjan
Thank you.
Agarwal and Dr. Ajay Yadav. Thanks a lot for the Mumbai Surgical Society Scientific Committee.
Thank
Looking
you.
forward to such
Thank
more
you.
lectures every week. Once
Yes,
again,
sir.
thank for the opportunity to moderate this session. Good night,
Yes.
everybody.
Thank you
Bye-bye.
so
Good
much.
night.
Thank you so
Thank you.
much.
Thank you.
Good night,
Thank you,
sir.
sir.
Good night.
Thank
Thank
you.
you. Thank you very
Bye-bye.
much.
Bye.
Thank you, sir.